first knew him, I'm going to say 10 or 11 years ago, when he came to talk to me about training, and I directed him out towards UC Santa Barbara to get training in PRT. And you can see that he, as we say in the US, took the ball and ran with it. So Dimitri, let's go forward, and we hopefully will have some time for questions. So please hold questions till the end. Eileen will silence everybody but the speaker, and we are off and running. It's all yours.
Right. So Fred, thank you once more. It's an honor and privilege to be invited to these meetings. Hi, everybody. So good morning to the States. I'll be there in a week. All right. Good afternoon to Greece. Okay. And Turkey. Okay. Because it's 4 p.m. now. And good evening to Australia. I know I've got a couple of friends there and patients that are actually watching today. Okay. So applying evidence-based approaches internationally. Well, this is, believe me, hard. And I'm going to tell you all my personal experience about the whole thing. So I'm a neurodevelopmental pediatrician. I did my postdoctoral studies in Yale. And then around 2009, 2011, I was very puzzled about how could I return to Greece, where things were so different than the States. Believe me, nothing can prepare you for the cultural shock and the difference you will find in practice, treatment, diagnosis, anything, you name it, it's different. So I asked Fred, how can I find something that is evidence-based, right? And actually to be quite, let's say, cheap for the Greeks, because Greece, as you know, it's a middle to lower income country, okay? And we didn't have a lot of trained people. So he introduced me to the UCSB, to the Kegels, for the pivotal response treatment, which is an evidence-based approach, naturalistic, for autism. And now we're up in Stanford, Fred. You know.
Oh, I know Lynn very well.
Yeah, I know, dude. Yeah. So I became gradually, in the course of years, level 5 trainer of trainers, and I think they liked my job, so they made me the international program coordinator. Nowadays, PRT is in over 25 countries, ABA is in more than 100 countries. So basically what I want to say is that it was a personal quest. Okay, why? Because when I went back, people treated me, I would say, not so nicely. In many cases, they were saying that you cannot diagnose a child before the age of 4 or 5. And you cannot have an early intervention before the age of 3, which is 0 to 3. It doesn't make any sense. So they were telling me, oh, Dimitris, you are in for the money because you just want money to apply, you know, just for early intervention. You cannot apply early intervention, so you're in it for the money. The average time of therapy per week in 2009 was 4 hours per week. In some countries like Turkey, it still is, okay, 2 to 4 hours per week. So you can understand that I was in Yale, I went to Benhaven, I went to foundation school. Fred sent me everywhere, and my professor Carl Weitzman, she says hi also, she's in Boston now, Harvard. So there the training was 25 to 50 hours per week. So the change was a big thing for me, okay? The other thing was that there was a lack of specialists trained in evidence-based practices. So when I went to Greece, the bulk, the major number of specialists were not exactly specialists how you know them. They had attended, they were of another discipline, let's say kindergarten teachers, and they had attended some trained, foreign trained therapists. Like we had, let's say 4 or 6 speech therapists, and some other people just attended their work and they named themselves, okay, speech therapist or occupational therapist. Okay, occupational therapist is not the case, but because occupational therapy was evident, it was in Greece since the 1950s by an American occupational therapist, by the way. The other thing was that I couldn't use, as Fred knows, almost none of our standardized US tests. Vineland is still to be standardized. ADOS was in very primitive states. Some training did exist. And also there was a lack a stigma, okay, in accessing therapy. People literally came up to me and they said, I'm not going to shake your hand. Don't get close to me because I'm going to catch autism from you because you deal with autistic children. So I figured out that I had to change something. And how do you get them interested? How do you get them interested, really? So I tried through the government. No, nothing. There was nothing. Okay. Greece had a lot of problems back then, and it still has. Although we do have a Harvard-educated prime minister now, he's relatively good. So I did a couple of seminars with my own expenses. Hi, Katerina, Kalispera. Okay, I actually pay out of my pocket. You know the phrase, yeah? Most of the seminars I do, I pay them out of my own pocket. Okay, because most of the people could not afford that. So patients and their families became interested themselves. And because they became interested in evidence-based practices like PRT, okay, because I know PRT, I do also ABA, I'm very good in teach. So I'm using different, okay, approaches when need be. So basically, the families saw the difference in results. So they began a private initiative. Nowadays, for example, in Greece, can you hear me? Yes, all right. So nowadays in Greece, I supervise a center for teenagers and young adults, okay? This center is similar to what Fred knows, like Ben Haven. So it's done out of a private initiative because there was a kid, okay? And the mother knows, and hopefully she's watching now, that they would not accept in any therapy center. They would not accept him for treatment, nor in school. Or the setting that they would accept him was a very, let's say, severe setting, was a setting for severely handicapped children. It was like a parking place, I would say. So from my personal experiences, private initiatives were almost the norm. Okay, then online therapy. I do have a lot of Greek Australian and Greek American families that attend me, okay? And we do online sessions, okay? We actually do parent coaching. These people, okay, they conglomerate, they come together and they say, okay, Dimitris, you show us the way, and we'll do either an online training, proper online training as a group or as a community even, all right? Or, okay, you come and train us. This has happened in several occasions, like Armenia, like Turkey, not so much, okay? Like, for example, in Germany. And other times, I did consult with Fred and I sent him over a couple of families to the Yale Child Study Center. And then when they came back, they said, all right, we want what we have there. So they wanted to actually find the same setting, okay? Hi, Danai, she's from Cyprus, okay, that they had seen elsewhere. Also, I did connect with physicians who had personal experience from the US and especially from Yale, and especially with physicians, child psychiatrists, although I'm a developmental pediatrician, who attended Fred, and they had Fred as Fred Volkmar, okay, as their mentor, who is the authenticity in autism. Okay, and also I did find a few developmental pediatricians, for example, in Turkey that had attended Yale. So the whole thing was that even if I wanted to train families or therapists alike, okay, if the therapists or the physicians, not the families, did not have an idea of what the results would have been, okay, especially from a training abroad, they wouldn't accept the possibility of these results. So what did I do? I started training families and children and specialists myself. And this disseminated in Greece the results. So people got interested. How come that family's child is talking and mine isn't? Okay, so it became a thing. I want what he's having. Okay, like the restaurant or something. Okay, but it did create let's say, a trend. And then I went on a TV show and I got them interested. They were interested maybe because it was a TV show, but the evidence-based method, which in this case was PRT, was good, okay? And it showed results. So the internet, especially now, the last 1.5 years, okay, people, families turn to the internet, okay? And the internet is also an inhibitory factor, but on the same way, many people came in touch with things that they would never have had. So let's go to the next one. So I did follow up on some Arabic countries like Saudi Arabia. Money was there. The will was there. No specialists. So we do have ABA therapies in more than 100 countries all over the world, okay? But it is said by studies from Wallace et al. That less than 10% of the world's population has access to evidence-based practices like PRT or RBA. So even if you have money, will therapists train you? And then will they even come to your country? Because we do get a lot of online training lately, but it is not enough. And you will see why later. Language barriers. Even if you use a translator, sometimes it's not enough. I don't want to brag, but I speak 18 languages. Fred knows about that, okay? And I'm getting on to my 19th, which is Albanian. And one of the reasons I have actually studied so many languages is because I wanted to apply what I have learned. And I will explain in detail later. Cultural barriers. Right, Kalispera to Athens. Okay, they know that I see people entering, coming and going. So cultural barriers. What applies to the States doesn't necessarily mean that it applies abroad. So even if you have a very good evidence-based practice, sometimes it's hard to convince them that it can be applied. I just want to bring out an example, right? You know Vineland test, yes? Most of you know the Vineland test. There is an item there that says, can he use the microwave? Okay. So when I actually asked that in Greece 11 years ago, 12 years ago, they were laughing. Why? Because they were not using microwaves. So basic things like that can make a parent lose interest or lose confidence that an evidence-based method that may be good, okay, can be applied culturally to them. And several other things like asking questions. Sometimes, although it might seem strange to our American friends, questions are gender-based in many cases. So you have to know the culture before you go in there, or you have to train somebody that will be bicultural, that will understand the two cultures. So from personal experiences, I have trained people in Greece, Cyprus, Turkey, Armenia, Argentina, Albania, many other countries I'm not saying here. I went into the country and I trained them, okay? Especially in Greece, Cyprus, and Albania, I've also translated my books. I speak fairly well Russian, Italian, French, Polish, Japanese, Portuguese in a lesser degree, and I'm almost, I'm like, it's like my mother language, German. I speak German as a baby. Okay, so basically, all these languages bear differences, and training people in several countries did give me an advantage on how communication in autism is viewed. Communication has also a social outlook and also a therapeutic or a deficit outlook. We'll talk more about that, okay, which is culturally induced in many cases. So I'm also conducting online trainings and supervisions about 10 other countries, Australia, the States, Saudi Arabia. I speak fairly well Arabic, okay, Sweden, Belgium, and Egypt. So when going global, never take anything for granted. What you know might not be suitable for that country. Surely, the guidelines for each evidence-based practice are the same, okay, the more basic the development is, let's say from 0 to 3, the more, the more easy it is to apply EBPs. So up to 3 years old, it's fine. Same words, same attitude, etc. But after that, okay, things change. Another thing is that in many countries, certain disciplines like speech therapists, OTs, occupational therapists are not the same, okay? Meaning that don't take up autism as a case, which might be difficult to comprehend when you're in the States. Yesterday, we had yesterday night for us, yesterday afternoon for Fred, we had a very nice seminar online with Turkey, Istanbul, right? And I was explaining to people that in Turkey, for example, we do not have speech therapists that take up families with autistic children. They're not involved. So mostly special education teachers are involved, and in a lesser degree, occupational therapists. When special education teachers are involved in Turkey, there is a problem, although they do mean well, and they're very, very, very elaborate people and very clever people, and they love their job and they love their children. So because they're teachers, and my grandparents were teachers, their discipline, their main direction is cognition. They think more about cognition. It comes like an innate struggle, okay? It's innate, it comes from within, that they have to teach the child. But they teach and they do more labeling rather than the communication. So I tell them that if you say, what is this? This is a pen. This doesn't mean it's communication. So it took quite a long time for them to accept the fact that labeling is not necessarily interactive communication. So cognitive goals, as I say here, were hijacked by communication goals. And not all therapists are necessarily available in a country, like I said, but on the same time that we lack on what we may say main disciplines like speech therapy or occupational therapy, I saw the advent of many complementary therapies or folk therapies. For example, unfortunately, okay, in Greece, I had children go to be exorcised. I know, they took them to the church. Okay, I love the church myself, I'm a believer, but aside from that, they went to the priest so the priest could get out the evil out of them. So you come up to cultural barriers that you wouldn't accept. So how do we go into a country and change things? Tackle the language barrier. You have to know the language, or you have to know the basics of the language. So why? Because if you take, for example, PRT, which is using mainly verbal abilities, okay, it is important to know the structure of the language. People who are English speaking have a great advantage. For example, you have a lot of words who are monosyllable. They have only one component. In Greece, you get almost no words that have only one syllable, okay? The other thing, English is a very straightforward language, whereas Turkish, for example, I speak fairly well Turkish, is an agglutinative language. You add things on the language. So when you start to apply methods, the practice in how to teach people, how to teach autistic children might have to change in the course of things. Other times, there is a context problem. For example, the Russian language lacks verbs like I am or I have. For example, in Russian, we say, to me there is, у меня есть, if I want to say, I have. Another language may not have plural or may have inclinations, which we do not have in English, okay? And other times, like in Arabic, the written form may differ significantly from the spoken one, from the oral form, which poses a problem when the child goes to school, because he will not see the same things that he speaks written on the paper, even if he understands. And the same thing, for example, I'm a Greek Cypriot. We use the Cypriot dialect, and it is not the same written speech. So you have to have a knowledge of languages. And also, regarding the language thing, you have to know the language because people will like you more. They will see that you're putting an effort. They will trust you more. So you have to be aware of the psychological factor. Challenges. There were in many cases a disconnection between the medical aspect and the intervention goals. Okay, there was a diagnosis, but until now, most of the physicians, the child psychiatrists, the developmental pediatricians only say you go and have OT/ST, occupational therapy, speech therapy, special ed, and that's it. They wouldn't actually say do this and this and this, not in all the cases. So when you apply evidence-based practices, the doctors have to be aware of how to implement this, although they might not be the implementers. The doctors have to be aware. So not just know what PRT is, but know how to apply it in order also to supervise the therapists and other people as well, and the parents. Because in some aspects, okay, what you see as symptoms might be a therapy that hasn't gone well. So what are you going to advise to somebody when you yourself don't know the therapy? So for example, if a parent is doing learned helplessness, you have to know ABA, have to know PRT, for example, on how to advise the parent to elude this obstacle, to evade this obstacle. Expertise by US standards could be limited in the country that you're going. So one of the problems I had, Fred, with the KEGOs, not with the cases themselves, was that they took for granted that people would understand the principles of PRT. Meaning that because PRT, for example, is based on ABA, and most therapists in the States know ABA, they wouldn't exactly elaborate in more detail. They would say, okay, he knows how to do it, but people don't know always how to do it. The other thing is that when I go to countries like Greece and Turkey, they do have a lot of online training or training on site for ABA, but these trainings are unofficial trainings. They don't have quality control. And exactly why? Because the official training is expensive. So money comes into this case as well. Age of diagnosis. It significantly impacts, okay, the course of the intervention, okay, and the results. So it started becoming evident to me that if I didn't train the specialists and the doctors especially, okay, I wouldn't get anywhere. Another problem that arose was gender and cultural barriers. Depending on each society, I know that for the States, this might be difficult to comprehend. There were gender issues. For example, in the Arabic world, it is more acceptable, okay, for a woman, okay, to treat a child, okay? Whereas in other countries, it might be more acceptable that the doctor is a man. They have more confidence, okay? Or vice versa, okay, they would say that men are inadequate trainers for children because exactly they don't have the motherly love. I was told exactly that, okay? And in some cases, even recently, when I started applying PRT myself to children, explaining them and showing them and rolling myself on the floor with the children and playing with the children, people looked at me funny because how can a serious professor, a serious doctor, okay, play with a child? And I was explaining to them that if you want to apply an evidence-based practice, you have to know it and you have to play with the child yourself. Another thing that was a problem in EBPs was that the grandmothers or grandfathers, the grandparents, were interfering very much with the therapy. So these are things that when you try to structure an evidence-based practice, you might not think of it why? Because they were a part of the family. Or in Japan as well, because many generations live in the same house. Okay, so another thing was that I didn't get enough supervision of my therapists after I trained. Okay, Fred, can you hear me well? Eileen, is it okay? All right, thank you so much, Wendy. Thank you. So there was a lack of supervision, which means that most people got trained. We have five levels until level 4. I think it's obligatory. It's not obligatory. It's useful, right? But people would get trained for level 1, possibly level 2, and then they would discontinue. And they would say, okay, I'm trained. So the quality control, okay, and the supervision is a must. So it's not enough applying an evidence-based practice, but it has to have a formal continuation. What I have proposed, for example, to the CAG is that people should get recertified, as in the States. Competition. So when I went to a country, and it has happened to me multiple occasions, some of the therapists didn't actually want to disseminate PRT or other methods or other tests and stuff because they wanted to keep the method as their own. And I told them, first of all, it's not ethical. Second of all, it's like Starbucks. You get Starbucks in every corner. Other people should enjoy that too. Okay. So when you do have an evidence-based method, in order to go global, okay, it has to be used like a well-meant Trojan horse. You have to introduce through the evidence-based method what the foundations, what the surroundings of this method are. Okay, and what is it? Tests, screening, early diagnosis, and therapy training. So when you think about an evidence-based practice going internationally, do not think only about the data, because what applies data-wise to the States might be very different because of certain factors as we're explaining, okay, locally. Okay, so PRT was easily adaptable, and also it was more cheap. So when I came to different countries, what I came up with against, to was that other methods which were not evidence-based were more cheap or cheaper. And that was a problem because they were more publicized. People would get trained and they would think, okay, it's enough. Other times, an evidence-based practice may fail because it requires many resources. As Fred said yesterday, okay, some other methods are time-consuming, money-consuming, and also the therapists to get trained are not knowledgeable in English, because it's not a bad thing, but most of the methods, okay, appear in English first. So we should emphasize the need of early intervention. So when I go into a country, I tell them, what is your population, your target population? Usually they would say school children and above. You know why, guys? Because that's when the system obliges abroad, okay, in most of the countries, to get in touch with a physician and get a screening or get tested, like a hearing test or ophthalmological test, blah, blah, blah. So when they came up to the school environment, like kindergarten or school, okay, it was already too late for children, okay, that they had autism. Early screening, okay. Before I came to Greece, I came in touch with Diana Robbins, okay. So I translated MChat in Greek and I posted it on the World Wide Web for free. And after that, we also held a seminar in Greece, okay. Why? Because I wanted to, let's say, sensitize people in Greece that they should get a screen. And also, okay, to get the word out that autism is here. Because unfortunately, when you go into villages, there was a big stigma, as I mentioned at the beginning of this session. Family training. This is a big must when you do EBPs. Why? Because most of the people, when you go to a new country, they think that only the therapist is liable for the child's training. Sometimes in Greece, I use this example, although it's not doesn't sound well. Okay, what do you think? Your child is a car, you take it to the service, to the car service? No, to the mechanic? No. Okay, you should get trained. Don't expect everything from the therapist. So you have to involve these different disciplines. You have to increase the hours, okay, that you teach the child. So when I went into different countries with PRT, I told them, okay, you might not have the money, but I'll get you trained, the family will get trained, and you can actually supplement, complement the hours lacking, okay, by doing training, by using your daily routine to train your autistic child in communicating, okay? Setting of the therapy. As I said before, they thought that the therapy can be done only in a therapeutic setting, in centers, okay? So I told them that, no, it can be done in the community, can be done in the family house, can be done in the pub, can be done anywhere. So especially Greece, Cyprus, and Turkey, okay, the introduction of PRT, which is an evidence-based practice, but this goes with anything, okay, is bringing change because it uses a family setting. I told them that you want to use that, you have to increase the age spectrum, okay, that you will apply this evidence-based practice, okay? You have to also, okay, so when I used it in Greece especially, I taught them how the different disciplines should work between themselves. I taught them, for example, that in Yale Child Studies Center, when I was there, every Wednesday we had a meeting and we would discuss the patients, the case studies, and we would all pay our respects to the different disciplines. I would hear very diligently what the speech therapist would say, what the special education therapist would say, okay? And we would all convene for the best interest of the child. Whereas in many cases in Greece, what they did, everybody was working independently. And you could only hope, okay, that their goals would meet. Time spent on therapy and the quality of life of families and children. So what Fred had taught me was that when a family comes to you, ask them, what do you need? What do you need us? How can we help you for your family, in your house? What is your dire need, your most distressing problem? And you use that problem as the axis of the solution. If the problem, for example, is toilet training, I would say, okay, you need a two-step command, you need a motivation, you can use the bubbles for the soap to motivate the child, okay, and you do a program, 1, 2, 3, blah, blah, blah. You can use the teach as a visual control, etc., etc., and you can use verbal commands. So I focused on caring for the families when I wanted to apply EBPs. So it was probably the most positive contribution, as it made adoption to the techniques when we train families, okay, easier, and there was a wider generalization, an increase in collateral gains because the families felt confident. And in conclusion, okay, when applying and drawing strategies for EBPs, data is important, but data might not be adaptable to the setting. So, first of all, know where you're going. Know the health system and the insurance system. because even if the parents want to apply some therapy, if they're not reimbursed for that therapy, it might not be helpful. The resources available, you have to know what kind of therapies are available there. For example, in Greece, I supported the training of many speech therapists because speech therapists were not exactly available. Like Julieta, for example, now she's joining us from Athens. I sent Julieta to New York and she got trained, okay? And because she's a very good speech therapist. Okay, money needed, okay? Wherever available, we asked for a discount. And we took in mind the average income, okay, that a parent had and was available to provide for his child. I have to say this for American friends, that the average pay in Turkey, for example, is around $6 to $8, and the average pay per session, as always, for the therapy in Greece, it's from 8 to 10. That's the net, let's say, value of the therapy. Whereas, for example, in Cyprus, the net value, the net gain, let's say, is around $30 to $50. Whereas in New York, it would have been 150, 140. So you have to know all these factors, because an evidence-based practice is good, might be well meant. I mean, but sometimes other factors, surrounding factors, cannot allow you to apply this method. The language, you have to learn, especially verbs for this training. Have to get in touch with somebody who knows the language, and you have to learn a bit regarding the culture. The average age of diagnosis may be crucial, because even if you have a good evidence-based practice, because the children in some countries start training late, like 4 or 5 years old, okay, that's when the system, okay, the government catches up with them, let's say, the governmental system catches up, or the educational system catches up with them. It might be already too late to apply the basics. It can be applied, but you won't yield the same results. Tests like Vineland, AROS, long-term goals, okay, and when you should revisit the results, when you should reevaluate. Just doing therapy, okay, is not enough. And the reading, the rate that you apply the EBP. So again, I will repeat that. Even if you have an EBP, it doesn't mean that this is applied in the same way as in the States. So it might be a good practice, but it not be applicable because of other factors. The inclusion of families and therapists alike. I insist in Greece, Turkey, and Cyprus especially, that therapists are including the families in the session. Most of them complain, but doctor, if I include the mother, the child will run up to the mother. And you know what I say to them? Fine. What do you think will happen when that mother is at her home alone with the child? How will the child generalize? So you devote, I tell them, the 15 minutes of a 60-minute session to get the mother trained and to see how she can apply basic event stuff with her child, how she can imitate you, copy you. And then you have to, okay, always bear in mind that people might not say, might not express the cultural and language barriers, okay, that are prohibiting you, inhibiting you of getting to them. So you have to study their culture. You have to study their language. So by this, okay, I'm available for questions if there are any, okay, and I would like to say a big thank you to everybody, especially in ancient Greek, which is epeno, which means I'm rewarding you. Okay. Thank you so much.
Oh,
Otherwise,
thank you.
yes,
Thank you. We have time for a few questions. Let's see, Eileen, do you want to let people unmute, or how would you like to handle it? You want to ask the questions?
Yeah, I have a couple questions that came through straight to me, and I can direct those directly. And then if anybody else has a question, if you want to just put it in the chat to the whole group, that would be fine.
I think this was a great talk. Let me just say, I think, Demetrius, the important really take home, I thought that you made the many points, but one has to do with respect.
Yes.
Remember Aretha Franklin, that talk about her song about respect, you know? But the other thing is how only 10% of the children around the world are really getting treatment, I think is a very sad statistic. And that's one of the things we need to work at, making things better. And that's, you know, one of the things you're so great at. I hadn't appreciated it spoke that many languages.
Yes, I'm doing also a second PhD in social anthropology, you know?
Oh, good for you. I only do Latin, and I don't even speak it. Okay, so let's open up to questions.
I'll tell you about it.
All right, so the first question that came into me was, what do you perceive about the needs of families to EBP, from different cultures in terms of their health belief, the attitude towards autism?
Okay, so what do I perceive? It depends many times in certain factors like religion and not so much education. Okay, for example, in Greece, I went and met the ecumenical patriarch. Okay, he resides in Istanbul actually. So he told me very interesting stories about autism. When I conveyed them to the Greeks, which are Greek Orthodox, okay, religion-wise, they really took it into their hearts. So in order to change the perception of people towards autism, you might have to think out of the box, okay? And another thing that is puzzling me, especially in high-income countries, Eileen, okay, and it would be interesting to know from which country somebody who is asking this question was, okay, is that the economical factor. If you have a high-income country, okay, you have to ask yourself, okay, what the theory behind this country is. In some countries, which are really advanced, autistic children do not receive good EBPs, good therapy. You know why? Interactive. You know why?
No.
See, she's not autistic. Okay, so because they're not productive according to what they think. So they have a connection of health, of a healthy person as being productive. So in order to tackle this obstacle, which is very interesting, I was reminded when I was in Yale, I went to a couple of schools and there's a program called ACES programs. I don't know if Fred knows that. Because
yes, very well.
Yes, of
very
course,
well.
There. So when I went to ACES program, okay, what I saw was that they had a catering company, they had a courier company like DHL, and they had a laboratory for doing Ruleman and parts for car parts and stuff like that, which was very interesting. So by showing them that autistic people can be productive, you can change the health beliefs, but it is a very tricky business. So I used what I had, which was the TV. Okay, I frequently went on a TV show, like Lynn Kelly went on to the Super Nanny. Okay, they used me, I used them. And they started viewing autism as something normal. And I told them, do you think it's normal that somebody speaks 19 languages? No. But here you have me. I'm giving you a seminar. So autism is about having your own perspective. And this is what I teach people. So can we move on to the next question?
Sure. The same person asked a follow-up question, and it's about the service delivery. Different countries have their own health system. What kind of delivery format do you think is most acceptable for families?
That's a very good question. Actually, thank you for who is asking that. I can see also Australia Okay, Sylvia, hi. Hi, Sydney. Good evening. Okay, so basically, okay, in Greece, we don't have a very good system. The money is not good, but the system is good. All right. They give you an amount of money and they say to you, you use it, you distribute this money, okay, according to how you want. They do have a quota, they do have limitations. But I would say that the best system would be, okay, a system that provides you with the resources, okay, but also connects you with the therapies needed. Because if you do not have the necessary therapists, no matter how much money you have, it's not going to be useful. So if I was to connect with the health system, okay, what I would do is I would ask each country to train its own therapists and then disseminate them evenly to all the countries. How? You can be licensed in certain counties, in a certain distance, blah, 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 blah. Okay, but it depends also on the governmental system. So what I would say is that can a system provide about 25 hours per week of therapy? I don't know. So you know how they managed that, they tackled that in the States, in Connecticut, which I know very well. Okay, parents started suing the government. Yes, I think Fred knows about that. So that's how schools, okay, became founded, because it was more helpful for the government to build schools and to provide proper therapy than paying the sue. Okay, is that right, Fred?
Absolutely, sadly.
Yes. So no matter what the system is, we have to look at the resources. So please.
That was the only other question I received.
That's perfect.
Yeah, you might have gotten some. You might want to check your chat.
Okay. No, it's fine. I would just like to say thank you again. I'm arguing this. You connect with me at Dr. Dimitriou, Dr. Dimitriou on Instagram, right, or wherever you want. I'm at your disposal. I hope we'll have a fruitful meeting next month as well. And thank you,
This is great.
Fred.
Oh, thank you so much for coming. This was wonderful. Thank you very much.
Yeah, and thank you, Eileen, too.
Thank you.
See you soon.
Thank you for all the support. We'll be in touch.
Hope to see you all
Okay.
next month.
Okay. Yes,
Bye-bye.
Bye-bye.